Hello, everyone. I'm stealing the thunder from Youssef for a moment, but we'll hand the mic to him forever because I have to get in the first word and tell you just how awesome it is that I get to co-discuss with him. I think nothing, as you all know, it's a little bit customary to roast slash thank the co-discussant on Thursday. And the truth is that Youssef's middle name is CP Solvers at this point. Yeah, Youssef and I met a little bit of a backstory a long, long time ago when he was an R2. And first conversation with him, I actually had it. I don't know. I think I've told you this. I had it and spotted a coyote at the same time in the Presidio Park, which was terrifying. But I kept my cool, and I'm glad I did. I'm glad I wasn't too distracted because that was the first conversation I've ever had with Youssef, and it became very clear that something very special was happening, meeting this incredibly talented, creative, and innovative person. And a few short years later, he is literally the peak of CP SARS, I would say. I think it's best personified by what I noticed. I wasn't able to make it, but I saw that Yusuf, you were scribing yesterday, which is I think considered sort of the introductory aspect of being part of the academy is to do that core task, and the very fact that you were up for it, I think speaks volumes to the kind of leader you are. So super excited to go discuss with you. We also have a very, very, very special case presenter, but maybe I'll hand the mic to you to say hello and do the honors.
Thank you so much, Rabih, for the warm introduction. I used to listen to the podcast while playing PlayStation for like 2 years before starting residency. So the first time I talked to Rabih, I was like, oh my God, I'm talking to a celebrity who I've listened to for years. He just doesn't know it, but I know him really well. So very happy to be part of the team. Thank you. Uh, Jeffrey, you want to introduce yourself?
Hey, I'm Jeffrey. I'm one of the rheumatologists at Duke. I've been interested in clinical problem solving for a long time. I've been following for many years, and I'm so excited to join you guys. I've been able to present some cases, and super excited to be able to present to you both, who I've gotten to know a little bit more, and have been just so excited and happy to be part of this community now.
Yeah, I just want to jump on and emphasize that I think we are incredibly lucky to have both of you and put the spotlight on you, Jeffrey. I think for those of you who are further on in your medical journey, you realize that like there are very, very few subspecialists who remain interested in the core aspect of diagnosis. A lot of subspecialty, especially in the United States, means an emphasis on what the subspecialty delivers in terms of therapeutics and treatment and research. It's very, very rare to have a subspecialist. Like Jeffrey remains so rooted in the first principles of patient care, which is getting the diagnosis right. So we're so, so lucky to have you here. And before I hand the mic to you, I think a little bit of honors to the folks who are making this happen. So we have Glenn and Lyra who are making this happen. So maybe I can hand the mic over. I see Glenn's videos off, so he may not be able to unmute and say hello, but let me give it a shot.
Okay, good morning, good afternoon, everyone. My name is Glenn. I'm a medical student in Botswana. I'll be doing the scribing today. I'm excited for the rheumatology case today.
Well, we never know with Jeffrey, but it's probably rheumatology, Glenn. Glenn, did you go for your run today or what did you take a break?
No, today I didn't manage. I have a hectic schedule.
Oh yeah, do you? Oh my gosh, that sounds busy. Life as a medical student is not easy. Thank you for taking time
Yeah,
to scribe today. We really appreciate it.
yeah, thank you.
Alrighty, over to another continent. Hi, Lyra. How's your day going?
Hi everyone, my name is Lara. I'm also a medical student from Russia. Nothing much, just preparing for my finals that are gonna take place on Monday. And I was actually going through the questions on rheumatology, so
Oh, look
Jeffrey's
at
case
that.
is really on point.
That's perfect. By the way, you introduced yourself as medical student, though. Listening to you discuss your first rapid fire yesterday, I think one wouldn't be faulted for thinking that you're an attending already. It was unreal. And you're getting some love from your case presenter, Elena, who herself was presenting like a seasoned attending. So a real treat to see you here and excited to nerd out. And hopefully your question practice will come in handy for the teaching point. All right, Jeffrey, take it away.
Okay, all right, this is super exciting. So we're gonna start this first aliquot. It's gonna be the presenting symptoms and then the review of systems. So this patient is in an inpatient for which rheumatology is consulted. The consult question is for COVID vaccination induced autoimmunity. So this is a 62-year-old woman. She said she was feeling fine at her usual state of health, no issues, no pain. Then she received her COVID vaccine 2 months prior to presentation. The next day, she noticed there's a new red rash on her face that was, as she describes, in a butterfly distribution. And she said that this was worse when she would go out into the sun. And then over the next few days to weeks, the rash actually spread to her arms and legs and persisted. 1 week after she got the COVID vaccine, approximately, she noticed she was having a little bit more joint pain and stiffness. She said that it was in her hands, elbows, wrists, knees, and ankles. She also said that this was accompanied by significant stiffness in the morning of about 1 to 2 hours. So she went to a PCP, and initially her PCP said, he wasn't really sure what it was, but he didn't really think it was related to the COVID vaccine. Maybe it was like fibromyalgia and a rash that was just induced by sun that was nonspecific. She wasn't that happy with that kind of diagnosis, so she saw a different doctor, and that doctor said that they suspected it was actually COVID-induced autoimmunity, and she was given ivermectin as a treatment. On review systems, she notes that she's been having new onset of hair thinning and hair loss, sicca symptoms of dry eyes and dry mouth, oral ulcers for which she's had in the past, but they've been maybe more frequent now. No genital ulcers. She does have some numbness and tingling in her toes that comes and go. And she says that lately now, she's been vomiting a lot. She says about like 35 times a day, and that's what's bringing her into the hospital. Her review systems is notably negative for Raynaud's and muscle weakness. And that's the end of the first aliquot.
Wow, Jeffrey, what a excellent first aliquot. Very rich with information. The first point is that patient feels like these symptoms are related to the COVID vaccine. And I think there's a lot of research that's coming out in the last few years related to like symptoms related to COVID vaccination, a lot of like CNS symptoms, and a lot of hypercoagulability that's been attributed. The issue is that it's been really hard to have like a spot correlation. It's not like, oh, you take hydralazine and then you have hydralazine induced like lupus. It's a little bit different. It's a little bit more vague. And I wish it was that correlation was that strong, but unfortunately it's not that strong, so we're still like learning a lot. So I think I will tackle it regardless of the COVID vaccine, and we'll take it from there. So I think so far we have symptoms related to like a rash on the face, it's around the nose, and then it sounds like we have some hair thinning, some joint symptoms as well, and maybe some oral symptoms, sicca symptoms as well, and oral ulcers. I think I'm gonna talk about a specific presentation, which is like rashes that involve the nose or the face, the nasolabial area. So I think the big buckets are obviously like lupus, and then the other like mimickers include sarcoidosis. Somebody said roseola in the chat. That's a good one. Seborrheic dermatitis is another one. And then the way you can narrow it from there is whether it involves the nasolabial folds, and you can look for other systemic symptoms. And the fact that it is photosensitive has also some data. It will be helpful to see if has the patient been taking any medications? Have they been taking doxycycline, for example? Then you might consider a photosensitive rash or voriconazole, for example. And then, but then here we also hear about joint symptoms and oral symptoms. So it's initially if we were initially thinking, is this a cutaneous only manifestation? But after hearing all these systemic symptoms, I'm more thinking towards a systemic syndrome going on. And I would want to know like the severity of this arthralgias and see if there's arthritis, and then see the particular distribution. Because here we hear hands, elbows, knees, and ankles, maybe the smaller joints with stiffness. So we're thinking maybe an inflammatory joint syndrome. And then these were my initial thoughts. Is I'm thinking like an autoimmune flavor, and I would want to ask these symptoms. And Rabih, I wanted to ask you, with all these symptoms, how do you narrow your thought process, or what questions do you think you would ask that you would help you clinch the diagnosis before the exam?
Oh my gosh, I think for me, I would recognize that it would be impossible really to clinch the diagnosis until well into the evolution of this case. And I think the reason um you can infer that is I think that it's becoming more and more clear as Jeffrey presents this case that this is a systemic disease. And I say that because the disease is not, as you outlined, limited to the face. It's the whole body in terms of the rash, the joints. And then when you start to hear that the patient has nausea with vomiting, you rarely have diseases that live at the surface that do so. So it becomes very, very clear this is a systemic disease. And the reason that I think it's going to be quite difficult to get to the bottom of it quickly is you can take a simplistic approach to systemic disease and try to stratify them as mass forming systemic diseases, with the idea being that somebody has lung cancer that spreads everywhere, or what is probably best labeled as a subradiological systemic disease. And I think here you can immediately get the impression that you're going to land in the latter. And the reason for that is that this patient has obviously systemic symptoms that we just talked about, but they don't have any asymmetry, meaning that the right side of the body is affected at the same way as the left side of the body. And whenever you have a symmetric systemic disease, the answer often lies in the blood work or the pill box, meaning exposures that the patient has or unique histopathological, unique signatures in their blood workup. And so I think that we're going to have to analyze a very, very complex landscape. And whenever the imaging is unlikely to be of profound help, meaning that the disease isn't kind enough to coalesce into a space that you could just remove and ask the pathologist to tell you what's going on, you know you're going to need to have some time. So what I would do now, honestly, is probably focus on controlling her nausea and seeing what other systems are involved. Does she have particular endothelial involvement? Does she have hematological involvement? Does she have renal involvement? Does she have hepatic involvement? What is the significance of her neurological symptoms? Is the alopecia a clue to the underlying cause, or is it a consequence of being ill? So there's so many open questions. I think to your original question about what the value of the exam is, I think the value of the exam is to see the severity of the systemic fingerprint, what are her vital sign abnormalities, and then try to figure out, is she having arthritis or arthralgias? Because I think that if it's an arthritis syndrome, the DDX is much more narrow than her joints ache, but they're not inflamed. So a lot of progress to be made, and I'm intrigued by the number 35. 35 times of emesis is is 35 times too many. So we'll see where that takes us. All right, Jeffrey, mic to you.
All right, amazing, amazing. So this next aliquot is just going to be about her past histories. So her past medical history is notable for diagnoses of GERD, osteoarthritis, fibromyalgia, and a thoracic ascending aortic aneurysm that's about 4 centimeters, and is currently just being monitored. Her medications include prednisone, zinc, magnesium, and pantoprazole, as well as the newly given ivermectin. She has no surgical history. Family history is significant for Huntington's disease in multiple family members, and then lupus in her paternal grandmother. As far as her social history, she works at a bank. She is monogamous with her husband, and they've been married for many years. She has one dog, and she has not had any recent exposures that were unusual or travels outside of the state or out of the country in the past 5 years. Her habits are significant for smoking. She said she smoked about a pack a day for about 7 to 8 years, quit about 20 years ago. Now she occasionally smokes, but it's only when she gets really stressed. It's very infrequent. She states that she doesn't drink alcohol except for on social occasions and has no recreational drug use. And that's a short aliquot, but that's the end of the second aliquot.
Yeah, thank you. I don't think I have a lot to add. I think as you were talking, Robbie, I was processing this information, and we see like the different symptoms fall in different autoimmune buckets, like the Raynaud's, the Zika symptoms, and the alopecia. They're falling under different autoimmune conditions like lupus, Sjogren's, etc. And we know they're all associated together. But as I'm like trying to localize or name a disease, I see that there's a variety of diseases that have these symptoms, and they could come together, obviously. And I'm glad we don't see any medications that can cause like photosensitivity, the history of the thoracic aneurysm. I think I'm not taking a lot of information from that. The most common causes of these like abnormal aneurysms, a lot of times it's like associated with bicuspid aortic valve, which is like congenital, and then you end up with disease there. Uh, Sometimes it can be associated with seronegative arthritis, but I'm not gonna put a lot of information there, and unless it's related to the case. And then the smoking history, I'm just putting that in the back of my mind, and no recent exposure. I don't think I have a lot to add. What did this aliquot do for you, Robbie?
Yeah, like you, I think you might put all of this in pencil and see what you're going to highlight. And I think that nothing immediately came to mind to highlight, though I think that the fact that she's only 62 and has a 4 centimeter thoracic aortic aneurysm is something to see if it matches a foreground that evolves in that way. The truth is that most of these aortic aneurysms are degenerative in nature, either as a result of a connective tissue disease, which may be focal, like a bicuspid valve, or systemic, like Marfan's. But they're often degenerative because of atherosclerotic disease. And so at 62, without a robust smoking history, it leaves the door open to the possibility that this might be not a degenerative form of aortic aneurysm, but rather an inflammatory degeneration. And so, I've come across some cases of patients with Takayasu's arteritis who have a monophasic presentation, or a very dulled presentation. In fact, just yesterday I was sneaking in on the rheumatology case conference covertly. Um, but I botched it because I logged in as clinical problem solver, so not very covert. But yeah, yesterday's case was a patient who actually had an FUO as a 30-year-old woman, and then had no interval symptoms, and was not diagnosed. But at 40, she presented with renovascular hypertension, and the hypothesis was that she had Takayasu's arteritis, and then had kind of been silent for some time, only for activity to pick up. So I didn't realize that Takayasu's could be so sneaky. I'd be curious just to ask Jeffrey what he thinks about that, but I think that's the question that I'm open to, but I don't have enough knowledge to ascribe a degree of confidence to that hypothesis. What do you think, Jeffrey? Is that a plausible thing, or?
Yeah,
Oh,
definitely. Takayasu's is one of the most difficult diagnoses because it can have so much strange presentations. You can have like just like unilateral involvement in like one branch of the aorta. You would think that, the presentation would be something like similar to GCA, but in a younger patient. But in
yeah,
reality, it has so many different presentations depending on which area is affected, and it can definitely be chronic or subacute, even without treatment for some time before it gets diagnosed.
incredible. All right, we'll keep our antennae up, Youssef. All right, Jeffrey, what you got next?
All right, so this is where the more fun part begins. So I'm going to talk a little bit about what brought her to the hospital, and then it's going to be her physical exam. So she had all those symptoms, and then the last symptoms that she was having, the most recent that we discussed, was this new onset of nausea and vomiting. So then, just probably 3, 4 days prior to presentation, she noticed like when she was touching her neck, there was new swelling in her neck. It wasn't painful, but it felt like there was masses on both sides of her neck, and she was worried that these could be lymph nodes. Again, she said, she didn't really feel pain there, but it was just very unusual. And then she, probably 2 days after that, so one day prior to presentation, developed just really bad breathing issues. Like she couldn't walk without having to take a deep breath and stop. And then in the setting of all this, she did say on and off she's been having fevers and chills, hasn't taken her temperature at home, and night sweats. And that's also kind of been going on for about 1 or 2 weeks. She's unsure about how long the lymph node swelling's been there because she's only noticed about 4 days, but she thinks it might have been for a little bit longer than that. On physical examination, after she is came into the hospital. Her vital signs are notable for a temperature of 103.4, blood pressure of 108 over 66. She's tachycardic to 118, and she's satting 94% on room air with an increased respiratory rate of 26. In general, she is in no acute distress. She actually looks great for having a fever of 103. She, on HENT exam, does have bilateral cervical lymphadenopathy that extends kind of probably from the upper neck area down to the lower neck area on both sides. I would say it's about 2 centimeters. It's round, it's not hard, and it's non-tender. She doesn't have tenderness of palpation of her sinuses. She doesn't have any redness or signs of inflammation in her eyes. On her mouth exam, she does have a few oral ulcers, and there's some stigmata of recent bleeding there, and they're located on both the soft and hard palate. Cardiovascular exam, she's tachycardic, but without any murmurs, rubs, or gallops. On pulmonary exam, she's tachypnic, but she's clear to auscultation, and there's no accessory muscle use. Her abdominal exam, she's soft and non-tender. In dermatologic exam, she does have an erythematous raised rash that is covering essentially most of her body, definitely on her face, in a butterfly distribution. It does spare the nasolabial folds, but it extends all the way down her neck, trunk, back, arms, and legs. So a very diffuse erythematous rash. On MSK exam, she does have diffuse tenderness to palpation across all muscles and joints, but she does also have synovitis on bilateral third MCPs, as well as synovitis of bilateral wrists. On neurological examination, she has normal strength and sensation on upper and lower extremity examination. And that's the end of aliquot 3.
Wow. Sounds like here we hear about marked inflammation, and we hear about subjective fevers at home and high-grade fever when she presented to the ER. So that's a confirmation of the inflammatory symptoms that she's been having. And we have these interesting symptoms. I'm going to start with the respiratory rate of 26. First off, I want to start off is that anytime I see a respiratory rate in the chart, my first instinct is to not believe it and go to the bedside and do it yourself. Because if you just put like an pulse oximeter or anything that counts your respiratory rate, it's often inaccurate. So even though the chart might mark even 18 to 20 is relatively high, so I usually go check it myself, and I would want to confirm that. And here we do hear that it's in fact like elevated, a high respiratory rate closer to 26. And I think with the lymphadenopathy, we're all worried about the upper airway. Could there be like a compression there or like a tracheal disease that we're not seeing on obvious like physical exam? But it's good that we don't hear any stridor, but I think prompt imaging of the upper airways is going to be performed. In terms of the lymphadenopathy and the rash, usually the buckets of lymphadenopathy is you could organize it many ways. One way to organize it is it like localized to a specific like the anatomic plane, or is it like systemic? And it sounds like here it's like bilateral cervical in addition to the rash. So I'm thinking like, this is sounding more and more like a systemic process going on. And the buzzword of sparing the nasolabial folds is making me consider SLE, and we do see evidence of synovitis as well. So I think what I would do from here is one, like assess the upper airway, see if we need to like manage before diagnosing. And then the possible diagnostic pathways we have include serologies, the CBC, and then eventually sampling the lymph node if needed as well. Because I think if you can palpate the lymph node, then you probably can sample it pretty easily as well. So I think those will be really easy pathways. And then I would want someone to characterize the rash better. So I think here I'm gonna like consult dermatology for better evaluation. Uh, in terms of the fever, There's so many abnormal findings here. So in terms of the fever, I think that also I would want to treat the fever and see if that was contributing to tachypnea as well, or is it tachypnea related to like a upper airway issue, and see if that helps. It is markedly elevated as well, which we knew that she was inflamed. What are you thinking, Ravi, with all of this information?
Yeah, I mean, I think that if you were seeing this patient, you would probably be pretty overwhelmed. And you can see that I think what we were worried about, that this would be a long diagnostic journey I think is panning out. And so I think here you probably just want to separate things and make sure that you don't lose track of a key clue. So you got the skin disease, the lymph nodes, the fever. And I think the one element that I think is going to be important because I think it might help find a focus of asymmetry is the fact that she's tachypnic and hypoxemic. And so I think, as we talked about, you're probably going to be chasing a lot of laboratory elements to understand what this disease process is. But I'm really curious what the thoracic signature of this disease is. Is she tachypnic and hypoxemic because she's hyperventilating and is uncomfortable and is febrile? Or does she have a specific thoracic manifestation? So right now, it's not time to solve this problem. It's time to define this problem. And I think the only question facing you right now um, before you decide to pursue diagnostic workup is, do you empirically treat her for anything? And I think that given the long-standing nature of her presentation and the diffuse systemic features, the probability of a pyogenic bacterial infection that would respond to antibiotics is pretty low. The only pyogenic bacterial infection that I can think of that looks like this is toxic shock syndrome, with an erythrodermic rash, a high fever, and a patient being pretty ill. But I think there's no reason to suspect that here in this patient. So I think the only thing that I would be actively doing is withholding antibiotics, because I think they can cloud the diagnostic picture, though I would understand why somebody would put them on in this circumstance. And then really just making sure that you don't lose sight of the all the elements that you're trying to track, and triggering a reflex workup for everything. So my reflex workup for her thoracic symptoms is not just a chest X-ray, it's a CT chest because it's been subacute. We've talked about that before. My reflex triggers for cervical lymphadenopathy or any lymphadenopathy is to make sure you get an HIV, an RPR, an ANA. And whenever you're thinking about lupus, there's a whole workup for lupus, which I won't outline, but that I would probably cross that threshold now. And then, like you said, I think whenever there's a rash, a biopsy is something that dermatologists think about, in addition to, of course, offering their expert analysis of what it looks like. So still in problem-solving mode, and curious to see where Jeffrey takes us.
Amazing, amazing. I love all these insights. So, I'm gonna go with the labs next in this next aliquot. We're gonna start with the CBC. Her white blood count shows a leukocytosis to 15.7 with 83% neutrophils. Her HNH is significant for anemia to 9.4 over 29.4 with an MCV of 83, so normocytic. And she has a platelet count of 197, so mildly thrombocytopenic. Her BMP shows a sodium of 131, a potassium of 4.1, a chloride of 103, bicarb of 16, a BUN of 24, and a creatinine of 1.1, which is above her baseline of zero point 0.7 to zero point 0.8, and a glucose of 130. Her LFTs show an AST of 17, an ALT of 14, and an alk phos of 102, which is within normal limits. Her LDH is high at 279, so mildly elevated. She has a serum uric acid that's 5.5, so normal, maybe slightly low. And a ferritin of 56. Sorry, the uric acid is 5.5, which is normal, not slightly low. Her total protein is 4.8 and her albumin is 3.0. Her CK is 10. And then finally, we have her urine studies. So her urinalysis shows 1 plus protein, 3 plus ketones, many white blood cells and leukocyte esterase, negative for nitrites or red blood cells, negative for blood. and she has a urine protein creatinine spot done that's zero point 0.4 grams per gram. And that is her, that is the fourth aliquot.
Yeah, so I think what this aliquot did for me is that I think the biggest thing I hear is that she has an anemia with an slightly elevated LDH, and I think I will want to make sure to get all the hemolysis workup, including the smear, a DAT test to check for direct antigen testing to see for antibodies, and I think we're really good at detecting severe hemolysis, just like we're really good at detecting like severe bleeding or severe sepsis, but we're not really good at detecting mild or moderate like cases. So sometimes can be tricky to diagnose hemolysis, but a slightly elevated LDH between 200 and 300, you usually is an indicator of hemolysis. You want to check for haptoglobin and a smear as a reflex and retic count to help you ensure that that is the case. Uh, we do see a neutrophilic leukocytosis. I don't think I'm putting a lot of information there. I think there's no world where this patient doesn't get like blood cultures initially, but I think I'm not putting any diagnostic value there yet. Even for the AKI, I think the degree of kidney injury is not severe enough that I'm putting diagnostic value there. I think it's one of those where like the creatinine the next day has diagnostic value. Like if the next day we gave fluids and we ensured there's no obstruction and the creatinine is 2, then maybe I'm going down that path. But if it's just a slight increase, I don't think there's, and who's someone who's vomiting 35 times daily, I don't think you need to put diagnostic energy there just yet. So I think, like you, Rabih, I think at this juncture, I think I would want hemolysis testing, a smear, ANA and complement levels, and that testing to see if there's like an autoimmune hemolytic anemia. We're gonna get HIV in cultures and then a CT of the neck and the chest. And I think the other pertinent negatives, I think it's nice that the CK is normal. I think that gives us a reassurance that maybe there's no like muscle involvement there. And the ferritin not being markedly elevated, then I think I'm reassured that this is not HLH or something in that spectrum of disorders. What about you, Rabih?
I'm right there with you. I think that, that I find the time course to be very, very helpful here because, if you just changed the story and made it acute, I think everybody would be screaming towards a pyogenic bacterial infection. But the fact that it's subacute, is very, very powerful. And if you really are confident that this is a subacute disease process, you can start to make your journey closer and closer to autoimmune diseases because the checklist for infectious conditions that can do this starts to dwindle and dwindle and dwindle. And then if you ask yourself, what is a subacute infection that causes neutrophilia? And the number of subacute infections that cause neutrophilia are pretty low. When you're thinking about an infection that lingers this long, that does so, it's usually a space-occupying pyogenic bacterial infection causing an abscess. And that usually causes a very focal syndrome, like a liver abscess or a kidney abscess. It doesn't cause a hectic systemic inflammatory syndrome. So I think you can really start to move away from infections, though your workup, I think, will have to include blood cultures and cross-sectional imaging, as you just said. And you can start to do the same thing with cancers, the idea being that the most common cancers that cause a fever are liquid tumors. And oftentimes, by the time they're causing a fever this high, their uric acid is higher and the LDH is higher. So, probably subconsciously biased by knowing that Jeffrey's here, but also trying to make sure that we don't skip over the important causes of fever. I do think that this case is coalescing to think about an autoimmune disease, but you really should be a little bit careful when you're invoking an autoimmune disease causing a fever of 103 and a neutrophil count. Most of the time, autoimmune diseases do not leave a fingerprint that is so characteristic of a pyogenic infection. But there are some, and we can either use that fact to proceed with caution, which we should, but also to take advantage of the fact that lupus does not tend to cause a super high neutrophilia. That IgG4 disease does not usually cause a super high fever. So the question really is, what kinds of autoimmune diseases do this? And the first thought that came into my mind, honestly, Youssef, was somebody with a pharyngeal element, with a rash, with a high fever, and with a neutrophilia, if you just made them a little bit younger, this would be Still's disease until proven otherwise. But the fact that their ferritin is low is a very, very powerful test that makes that less likely. So I sort of like tempered myself and said, okay, let's not get ahead of ourselves. How can we understand the syndrome better, even though we're making progress towards autoimmunity? And I think there's something to be studied about the UA. And I say that because most of the time we study the UA in the context of a systemic disease to look for glomerular involvement. And I think the probability of glomerular involvement is pretty low. But it's hard not to ignore the fact that she has a large amount of pyuria. So I'm curious when you're thinking about pyuria, Youssef, how do you get more juice out of that space?
Usually I think like obviously the first thing is like you make sure there's no like infection, especially if there's no symptoms, and then the second bucket is considered like could there be like an interstitial renal disease as well?
Yeah. Yeah, I'm right there with you. I think when you say infection, you're talking about pyogenic infections in the bladder or in the kidney, and I think the time course makes that a little bit less likely, though you would want to make sure with a culture and or imaging. And so you essentially you step back and start to think systematically, where is this person inflamed in her urinary tract? And the fact that she doesn't have dysuria, and interestingly, the fact that she does have some proteinuria, and I would say that she also has a non-gap acidosis. A non-gap acidosis may be part of the spectrum of what's probably better called tubulointerstitial diseases, with the tubular aspect being a renal tubular acidosis and the interstitial aspect here being her pyuria. So I think it's just so important not to leave any powerful clues behind. And so I'm proceeding by querying whether this UA is suggestive of tubulointerstitial disease. And the way you can make progress on that is to go back and say, okay, what can I do about the tubular part? And what can I do about the interstitial part? And about the interstitial part, you can look at this urine under the microscope to see if she has white blood cell casts. The presence of white blood cell casts is virtually diagnostic of interstitial nephritis. What can you do about the tubular part? Oh my gosh, this is the one time where you might really care about the FOS. If her FOS is low, that might be very, very suggestive. You might look for evidence of, even though her serum glucose is not above 180, you might look at the UA to see if she has glucosuria, which she doesn't. But now you look back and say, wait, what about that uric acid? In somebody who has AKI, they tend to actually be hyperuricemic as a result of that. So is she having uric acid wasting? And is that a clue to a tubular element of it? In which case you might want to get a uric acid clearance. So what progress is my mind making is the same as yours. I think imaging would help you figure out, is this truly subradiologic? What is this? What is the extent of her lymphadenopathy? Is her spleen involved? But then also not leaving a clue behind that her kidney may be a focus of disease activity to study in the form of tubular interstitial disease.
Yeah, that's a really good thought, and especially the that it might have diagnostic value too if it's related to autoimmune disease. You're thinking of like Sjogren's spectrum disorders, so that's a really good thought.
All right, Jeffrey, we have us very, very intrigued.
All right, I'm gonna go actually to the I'm gonna go to the additional labs first, and then the last aliquot will be the imaging tests.
Okay.
So the additional labs are infectious diseases and rheumatologic labs. So from infectious disease labs, she had a viral respiratory panel, which included the COVID, flu, and the other many other viruses, which was negative. She had multiple cultures done, blood cultures, urine cultures, sputum cultures. So blood cultures were negative, sputum cultures were negative. Urine cultures were positive for pan-sensitive E. coli, but she did not report any dysuria, urine frequency, or any symptoms of a UTI. She had an echo done that showed no vegetations. It was a TTE, not a TEE. And then she had testing for hepatitis B, hepatitis C. She had a HIV, EBV PCR, CMV PCR, Quant TB Gold, a syphilis FTA antibody, and a histoplasmosis urinary antigen. And all of those were negative. So that was her infectious workup. And then her rheumatologic workup at the time showed an ESR of 27, which was normal, a CRP of 14.6 milligrams per deciliter, which is high. Uh, with our cutoff, over 1 is high. So hers was 14.6. She had a rheumatoid factor that was slightly elevated at 16, with the normal cutoff being 15. And CCP was negative. ANA was negative. An ENA panel was also checked, but was negative. Complement C3 and C4 levels were normal. And then finally, she had ANCA testing done. She had positive P-ANCA and C-ANCA. NPO was positive, and PR3 was positive. And that's the end of this all plot.
Fascinating.
Jeffrey, sorry,
Yusuf,
go ahead, Robbie.
I was just gonna say to Yusuf, do you think it might be a good time for a breakout room? What do you think?
Yeah, let's do it.
Yeah. All right. So we'll just do a 3 to 4 minute breakout room and we'll come back in a little bit, okay?
Ready.
All right, go for it, my friend. What was the conversation like?
Surprisingly, I find the pan antibody positivity a safe place or a comfort zone for me. So, so finally, Jeffrey, thank you. No, but I think now that we have multiple antibodies that are positive, I think a negative ANA is makes lupus much less likely. And then having multiple positive serologic markers has possible diagnostic value. And I'm gonna break down the causes in terms of buckets. I think the common one is endocarditis, and here we have a echo that is negative, and then the culture that is negative too. So you want to think of like, could it be a culture negative endocarditis that we didn't see on TTE, that we only see on TEE? And then if you think of culture negative endocarditis and zoom in closer, the causes of that are usually you can test for them serologically, like Brucella, Bartonella, Coxiella. So I think you will test for those regardless of if they have endocarditis or not. So that's a common infection. Syphilis, we have a negative RPR here. It's not 100% sensitive. You can have the prozone effect and etc. But usually it will be negative. So that's number two in terms of infections. Endocarditis we already mentioned with cryo, it can cause like some positivity. In terms of in terms of exposure, uh, silicone is the most famous one where you have like an implant somewhere and that leaks silicone. But also like adjuvants from vaccines could present like this. You can have like a adjuvant in the vaccine that hypothetically could cause a presentation like this. And then in terms of malignancies, there are like some leukemias that can also present like this. Uh, so what I would do next, I think I would get the Brucella, Bartonella, Coxiella serologies and a cryo, uh, knowing that they will likely be negative, but I think uh, these are things that you would want to rule out early on. And then what I would do otherwise, I think after those testing, I don't think I would get a TEE unless we see any signs like of endocarditis, which we don't see on exam or at all. And because even then the organism would be, you might be able to detect just on serology, unless Jeffrey tells us like the fifth aliquot, the cat walked into the room, and that's how the diagnosis was made. And then we don't hear a history of silicone exposure. And I think the diagnosis of exclusion would be like an adjuvant exposure. And then I don't know if you would sample the lymph node, look for malignancy somewhere, try to sample maybe the skin or the lymph node, and then if all of this is negative, then you would say, okay, this is just she was exposed to something that caused this autoimmune disorder. What are you thinking, Robbie?
Yeah, right there with you. I think that whenever you have an inelegant autoimmune panel, all of Jeffrey's diseases are very elegant. They obey very, very specific rules, and they all have to line up. And when you have a chaotic antibody panel, you know that Jeffrey might have to treat the problem, but you have to figure out what the source of it is, meaning that the patient might need temporary immunosuppression to prevent disaster, but you have to look for what the exposure is. And as you just said, and I'll just try to simplify, the exposure is either exogenous, often from a drug or an infection, but more morbidly, the exposure is endogenous, and by that I mean a cancer. So the thoughts crossing my mind are, is this the vaccine or is this the ivermectin? And I would probably, although I don't know for sure, venture to guess that it might be more likely the ivermectin than the vaccine. But the no misdiagnosis for which this is a classic presentation is a specific subset of lymphomas, the lead example of which is angioimmunoblastic T-cell lymphoma, which causes an erythrodermic rash, subtle lymphadenopathy, high-grade fevers, neutrophilia, and antibody chaos. So I would really want to not make, I would not want to miss that. So I think that the real question here is, what's up with the lymph nodes and do we need to biopsy them? And I think after that, in your back pockets are, is there an infection, which, as you already said, low probability, or is there a drug-induced autoimmunity? But I don't think this is a pure rheumatological condition. There's something else putting oil in otherwise pristine waters here, and we gotta find out the oil. All right, Jeffrey, mic to you.
All right, so ready for the last aliquot. This is super exciting. So this last aliquot is going to be the imaging. So this patient got a CTA PE protocol to roll out PE in the ER. It showed no pulmonary embolism. There was diffuse ground glass opacities that they said was consistent on appearance with pulmonary edema, bilateral small to moderate pleural effusions, and a small to moderate pericardial effusion. There was bilateral mediastinal and hilar lymphadenopathy, left axillary lymphadenopathy. They said it was unclear whether it was reactive or it was like concerning for malignancy. The size was like maybe larger than what they would have expected. And they were also given the history of the patient, of course, beforehand with this concern of, is this some type of drug-induced autoimmunity, infection, or malignancy? So that was the CTA PE protocol. And then the patient already had a PET CT scan, and that showed hypermetabolic bilateral cervical lymphadenopathy. But importantly and interestingly, it showed no uptake in the mediastinal, hilar, or axillary lymph nodes. And then it showed diffuse uptake in the spleen without splenomegaly, and maybe some low-grade diffuse uptake in the bone marrow, but that was not specific. And that is the final aliquot.
Dun, dun, dun. What do you think, Youssef?
Uh, and Jeffrey, I'm just confirming that the HIV was negative.
HIV was negative.
Sounds good. I think we have significant reticuloendothelial involvement, including the bone marrow and the spleen. And this is most commonly caused by lymphoma/leukemia. Prevalence-wise, I think it would be significantly like these two causes would be like the majority of cases. And then after you surpass this roadblock, which is leukemia or lymphoma, which is you have to surpass it every single time because it's the most common cause. That's where you go into like rare causes where you think of like zoonotic exposures, like we mentioned already, the Brucella, Bartonella, Coxiella, which I also don't think of as involving the marrow, but they do involve the reticuloendothelial system, and histoplasmosis, which also can also involve it. But I think this is after ruling out the lymphoma hypothesis. So I think next steps, like Rabih said, I think is sampling. I think getting a sample either from the lymph node or the bone marrow. Now we have that confirmed. If we have like confirmed bone marrow activity, I think that might be a incentive for hematology to sample it, or a lymph node. I guess now we know where it's active, so they can just go for the bone marrow potentially and see that. Although that can be tricky because just if you have hemolysis, the bone marrow may be active as well. So I think that's where I'm at. Anything for you, Rabih, diagnostically, and what else would you do?
Yeah, no, I think that I'm right there with you. I think tissue is the issue here. I think there is a little bit of a proportionality here, Youssef, that's worth getting some juice out for 30 seconds, which is the metabolic activity of the lymph nodes compared to the hectic inflammation. So you probably would have expected in most people that with a fever of 103.5 and a white count of 15, that their lymph nodes would be burning through, but they're not. And so, what conclusion can you come from that is that that supports the idea that there is a disproportionate cytokine-driven inflammation out of proportion to the lymph nodes. And the reason you might have anticipated that even before you got the PET-CT scan is how underwhelming the LDH is. So you can then ask yourself, okay, if I'm looking for a tumor, what kinds of tumors disproportionately cause fevers not proportional to their tumor burden? And the classic example that we've all learned in medical school is the Pell-Epstein fever of Hodgkin's lymphoma. So the amount of Hodgkin's and pathological cells, the Reed Surmer cells, or maybe there's 5 bad cells in your body, everything else is a reaction to them. And the checklist, in addition to Hodgkin's lymphoma, is angioimmunoblastic T cell lymphoma. There's a vascular response, a B cell response, and then Castleman's disease. So those are the 3 things that you would use that fact to prioritize. Um, and I think we can learn from Jeffrey, but I would say that if you remember Lyra's case that she presented from Alec, the a degree of chaos in the lymph nodes in terms of tumor burden was proportional to how sick the patient was. Here, the lymphadenopathy is relatively underwhelming. You can also take advantage of the fact that the lymphadenopathy here is asymmetric. The left axilla is involved, but the right wasn't, if I heard correctly. So there's some subtle things that you can use to have an educated guess of what this might be. And for reasons I'll skip over, but my sense is I would worry most about AITL here. Um, it doesn't matter so much, but it in some ways it does because you really have to inform your pathologist what your clinical suspicion is, because some of these things, actually all 3 of these things, Hodgkin's, AITL, and Castleman's, are very hard to find and diagnose accurately. So if you can give your pathologist a little bit of a heads up about what you're worried about, you may actually help your patient. Alrighty, mic to you, Jeffrey.
Jeffrey, before you just reveal, I'm just gonna share one final poll so people can vote on what they think the final diagnosis is before you reveal. And I put in the options as like lymphoma, Castleman, infection, or substance.
I like how autoimmune disease is not an option on this poll.
Hey, based on your last case, which I won't reveal to people, we now all approach your cases with caution.
A lot of times the room consults are to tell them that it's not a room diagnosis. So I'm gonna end the poll and I'll share the results. But basically, we have 2/3 voting for lymphoma and even split between the rest. So back to you, Jeffrey.
Okay, yeah. So awesome, awesome. This is such a great case. So I'll say we only really actually made one recommendation from this case, and I'll tell you why. So I was actually a fellow when we had this case, and my attending Dr. Jen Rogers at the time, she is our lupus clinic director. So she sees lupus, day in, day out. And all up until the point where the ANA became negative, we were like, okay, I mean, sounds like lupus, like everything kind of fit. And then once the 8-8 came back negative, we were like, okay, that's not really probably what we're thinking anymore. And then after everything else came back, I think both of us were thinking about the same thing. Could this be angioimmunoblastic T cell lymphoma? So our only recommendation, we could have done so many things. All the things that you guys have said, skin biopsy, bone marrow biopsy, sending more serologies from both autoimmune or infection. All of those would be reasonable and things that we could have done. But in this patient, all we did was recommend to stop the steroids and get a lymph node biopsy. We got an excisional cervical lymph node biopsy, and it became positive for angioimmunoblastic T cell lymphoma. So, Robbie's completely. Thank you so much for sharing your insights because I'm still learning from Robbie too here about the LDH and the kind of the disproportionality. But some of the teaching points here, now that I've studied a little bit more about how that specific lymphoma presents, I completely agree, in terms of the causes of, so any lymphoma can cause cervical lymphadenopathy, but a lymphoma that presents initially as cervical lymphadenopathy and not a diffuse lymphadenopathy is a little bit of a separate subset. So, out of all the lymphomas, and we split it into Hodgkin's and non-Hodgkin's, so the most common lymphoma is diffuse large B-cell lymphoma. So that lymphoma is almost always going to be the correct answer if you were just to, like someone to ask you a question about what lymphoma could it be, because it's the most common. For example, the most common lymphoma in a patient with lupus or in a patient presenting as lupus is going to be that, but that's just because it's the most common lymphoma. And so it's also probably one of the most common lymphomas that actually presents as cervical lymphadenopathy. And then we think about other lymphomas that they're less common but present classically as cervical lymphadenopathy. And Hodgkin's is actually the classic one. But the interesting thing about Hodgkin's is actually, so Hodgkin's is split into two subtypes. There's classical, which is 95% of cases, and then 5% of the cases is nodular lymphocyte predominant. So in 95%, the classical Hodgkin lymphoma, stage one is unilateral cervical lymphadenopathy. And then it almost always travels contiguously down. What that means is after unilateral, the next thing it should cause is mediastinal lymphadenopathy, and then it should cause B symptoms at that point. So stage one, unilateral. Stage two, it has some other involvement, and then stage 2B is B symptoms. And the reason that the stages work like this is because it's actually very classic. It almost always occurs in that pattern. So to have bilateral cervical lymphadenopathy, very atypical for Hodgkin's and fever. But of course, it's definitely in the differential. But I think that was just an interesting point that I learned about Hodgkin's. And then if you think about things that cause both really high fever, cervical lymphadenopathy, and then negative lymphadenopathy anywhere else. And the reason I say negative here is because PET CT is sensitive enough to pick up 97% of aggressive lymphomas based off of literature review. So indolent lymphomas, it may not pick up, but if this patient has a 103.4 fever and it's not from an infection, it's actually from the lymphoma, the lymph nodes that are involved by the lymphoma should be picked up in the aggressive lymphoma. So here I'm interpreting it as like the lymphoma was only in the cervical lymph nodes and the patient has a high fever. Just those two things alone make angioimmunoblastic T-cell lymphoma already one of the highest diagnoses on the differential diagnosis list. I'm really curious to whether this rule really applies or not. This is based off of my extensive literature review. So I'm really curious if anyone else has any cases that they can share of bilateral cervical lymphadenopathy and high fever from a lymphoma that's not from angioimmunoblastic T-cell lymphoma. And then finally, from a lupus rash standpoint, we always, we almost always recommend a skin biopsy. In this case, I don't know why I guess we were so confident it was some type of lymphoma, but the most common mimic from a lymphoma to cause a mimic of lupus are two lymphomas. They're both T-cell lymphomas. One's called subcutaneous panniculitis T-cell lymphoma, and the other's called cutaneous gamma delta T-cell lymphoma. But the hallmark of these and the way that they mimic lupus is that they actually cause what's panniculitis, which looks like erythema nodosum or lupus panniculitis. This patient doesn't have that. And also, they don't usually present with lymphadenopathy. They almost always just present with the rash part. So adding the lymphadenopathy picture puts that also down on the list. But but yeah, this is such a great case, and I'm so happy to share with you. And I'm not surprised at all by Rabih figuring out that it was angioimmunoblastic T-cell lymphoma. Always super, super, super impressive. If anyone has any questions, you can feel free to ask or put in the chat. But otherwise, thank you so much for allowing me to share this case.
Youssef, I think Jeffrey's pretending to be a rheumatologist. I think he just taught us more than many oncologists have taught us about lymphomas. But I'm curious what your reflections are before we hand the mic to Lyra.
Uh, First of all, incredible teaching, Jeffrey. Wow, that was amazing. Thank you for teaching us. I love the proportionality of fever or inflammation to lymphadenopathy, and then location of lymphadenopathy in terms of, in relation to fever, and how that can have diagnostic value. So nothing to add. Thank you for teaching me. Can't wait to learn more about this diagnosis.
Yeah, Yusuf, I'll just share that. I think, the way this case was broken down systematically up until the last part really sets us up for the key aspects of this case. And I think that for me, the pivot point comes when you say, "Oh, I'm now in my comfort zone about the antibody craze," and I think that schema really allowed us to get as much progress towards the finish line, and that was really, really cool to see. I just want to make a point to all of you because something unusual is happening now, which is that you're seeing how little research is done to really zoom in on profoundly helpful diagnostic variables that are not studied. So you ask yourself, like, how many randomized control trials are done about optimizing the treatment for lymphoma? And the answer is bajillions. How many close, uh, rigorous scientific studies are done to assess how subtleties of what Jeffrey just outlined, bilateral cervical lymphadenopathy with a hectic fever, like that data is all out there, but yet for some reason, the way medicine is set up is people don't study that or publish that or do that rigorously. So I really, really appreciate when people like you all showcase that deficiency and are just doing the brute hard work yourself. So that was a master class, Jeffrey, let alone in a field that isn't technically your own, but I think you might not be able to treat patients with lymphoma, but I think you can diagnose them just as good as any oncologist. That was awesome. Thank you for a really, really cool hour to both of you. It was a real treat. And thank you to Glenn for keeping up with all the scribing. That must have been a little tough, but you did a really good job. All right, Lyra, mic to you, my friend.
Yeah, thank you all so much. Thank you, Dr. Shen, for this amazing case and even better teaching at the end. We're already kind of in overtime, so I just want to emphasize really important things that are that were featured in this case. In first is that autoimmune diseases and rheumatologic diseases in general are really smart and really precise, and there is always certain criteria for the diseases and certain autoantibody types for diseases. And when we see that there is something happening here that does not make sense, we can activate autoantibody craze schema and think about infections, firstly of culture negative endocarditis and infective endocarditis in general, and also syphilis and granulomatous diseases also. Then we can switch our thoughts to malignancy theory. And here we need to think about LGL leukemia and angioimmunoblastic T-cell lymphoma also. Then we can think about exposures when all of the previous workup was negative. And here we can think about things like silicone drugs and adjuvants in the vaccines, because this takes the last place because this is hard to prove and this is generally a diagnosis of exclusion. And to overlap and make progress in this case, we also thought about the inflammation, clinical inflammation that was going on in the patient that was really disproportionate to LDH and lymph node metabolic activity on PET scan. And with this, we can make progress of Hodgkin lymphoma, angioimmunoblastic T-cell lymphoma, and Castleman disease. And to see how these two schemas overlap, we basically come to a conclusion of angioimmunoblastic T-cell lymphoma that was confirmed by lymph node biopsy. Thanks, everyone.
Oh my gosh, the ability to do that concisely was unreal. Thank you so much, Lyra. Big, big kudos to you. For those of you who are part of the CP Solvers Academy, I just realized why Elena and Ethan made the rapid fire session at 15 minutes after the hour rather than at the end of the hour, knowing that that Jeffrey's presenting a very, very special case to us. So thank you all. Youssef, amazing job as always. And thank you, everyone. Hope to see you around tomorrow. Bye.